Good afternoon, everybody. Thank you for coming. My name is Mike Clegg. I'm the dean of the school, and my job is to introduce the introducer. So I'm introducing Peter Augrey, who most people in the room probably know, but for posterity's sake, I'm going to go through a relatively formal introduction. Peter is a professor here at our school in the Department of Molecular Microbiology and Immunology, and he directs the Johns Hopkins Malaria Research Institute. Everybody who knows Peter knows that he's from Minnesota. He cares passionately about Minnesota, and he went to college there at Augsburg College and studied chemistry and received his medical degree here at Johns Hopkins. He went from Hopkins to Case Western Reserve in Cleveland to do his residency, and then he went to UNC, University of North Carolina, to do a hem-onc fellowship, and then came back here to Johns Hopkins. And Peter became interested early in his career in medical school in the pathogenesis, molecular pathogenesis, and mechanisms of diarrhea. And then, after he trained in hematology, worked on the red cell membrane, but is most widely known for discovery of the water channel protein that he named aquaporin. And then Peter has won many awards. I guess the one he's most proud of is the Distinguished Eagle Scout Award from the Boy Scouts of America. He won also the 2003 Nobel Prize in Chemistry with Roderick McKinnock for his work on aquaporins. He's a member of the National Academy of Sciences and the Institute of Medicine. He was president of AAAS, and from 2009 to 2011 served as president and chair of AAAS, and has led numerous scientific diplomacy visits to many countries, Cuba, North Korea, Burma, and has a passion for using science to improve both the health of people around the world, but also the ability of people around the world to communicate and to talk. He's married to Mary, who's a teacher, and he has 4 children. So Peter, please come up and give the introduction.
Well, thank you very much, Mike, and thank you all for coming over this afternoon for the talk, not a lecture, a talk. It's my privilege to introduce Lois Quam, the Executive Director of the U.S. Global Health Initiative. It's located in the State Department. She reports directly to Secretary of State Hillary Rodham Clinton, where she organizes and coordinates multiple agencies involved in global health, such as the USAID, the Center for Disease Control and Prevention, President's Emergency Plan for AIDS Relief, President's Malaria Initiative, and many others. Bringing these together for unified and integrated actions is a huge job. Lois is really an ideal person for this. I'm particularly delighted. Lois hails from the Norwegian community in Minnesota. There are 2 of us here now, so watch out. Lois attended Macalester College in St. Paul, Minnesota, and those of you who don't know Macalester should find out about it. This is a gem of a school which has a tradition of graduating young people who go into public service, Walter Mondale, Kofi Annan, and others. Lois was an outstanding student. She won a Rhodes Scholarship to Oxford, where she studied philosophy, politics, and economics, returning to the United States, where she focused upon healthcare economics. While only in her 20s, she was tapped by the governor of Minnesota to chair the Healthcare Access Commission, which led to the provision of healthcare for tens of thousands of individuals, making Minnesota having the lowest uninsured rate in the United States at that time. She then was tapped by First Lady Hillary Clinton to participate in the task force on healthcare reform, being a senior advisor on rural healthcare issues. She returned to Minnesota in the business realm, where she held key management positions. At the United Health Group, she forged an amalgam with the AARP, formed the Ovations Healthcare program, which provided healthcare and products to seniors, and served as president and CEO of the United Healthcare Group, which covered the needs of 20% of all Medicare beneficiaries in the United States. For this, she was recognized by Fortune magazine as one of the 50 most powerful women. And she has then last year taken on the job as Executive Director of the U.S. Global Health Initiative. She's also a trooper. She just returned late last night from Uganda, and she's been busy this afternoon meeting with our students and our faculty, and it's really a privilege to have Lois on our campus. Please join me in welcoming Lois Quam.
Well, tusen tak, Peter. That's how we say thank you in Minnesota. It is such a privilege to be here. You can't work in American healthcare or work in global health without admiring this institution and all its historic achievements. And just being here today and seeing the paintings on the wall and the pictures on the wall and meeting students and meeting faculty here today remind me of the national and international leadership that this university and this School of Public Health has played. And what I'm here to tell you today is that your leadership is needed in the future. Your leadership is in fact needed now. We're at a pivotal moment in global health, and I think the leadership of this institution will be very fundamental to our success in transitioning to what I think will be a new era. And that's what I'd like to talk with you about today, and I'm going to hope to save a lot of time for your questions. So I will ask you to get them ready. This institution has the word tropical hygiene in its name. And I remember when I was at Oxford, we talked about international health, still very focused on infectious disease, and still very focused on something that was over there. And today when we talk about global health isn't different than domestic health. It's really capturing a more global world where disease can spread in new ways. It's capturing a world where the threats of global health are not simply that of infectious disease, but we know in the developing world the non-communicable disease, cancer, forms some of the biggest health threats that are faced. So we're together. Global health in a way captures how we're all together. Now, it's a pivotal moment in global health, and it's going to require new leadership. And part of that is going to be challenging because we're going to have to sort of live in one world while we create another world. And I think the role of universities become very pivotal for that because you reflect that. In the students that I met with today, you see our future. And it is imperative that we think about how we can live in and succeed where we are today as we go forward. Universities are transformational because they educate the next generation. I was with one of the graduates of this university in Uganda, the CDC director, Tedosek Wahib, and he in many ways captures what a university can do in transforming the life of one person in this aim. Tad was born and grew up in Addis Ababa. His father died before he was born and left his mother with 6 young children. He was adopted by his uncle's family. His uncle was a religious leader who'd been at Princeton and had come back to Ethiopia. When Tad was in his teens, his uncle was imprisoned by the new government. He was, after 6 years, left out of prison, returned immediately to the United States, and ended up in Albany, New York, where he talked about his young nephew and what a bright young man he was. And this small Catholic parish affiliated with a small Catholic college, which I had never heard of, and I understand he's the first graduate that you accepted from this college, the College of St. Rose. They sponsored him to come to the United States, and he finished high school and started college, and then was enrolled here for medical school. He was the first student from Ethiopia to be enrolled at Hopkins for medical school, and the first from the College of St. Rose. And he shared when I was with him in Uganda how grateful he was for Hopkins to have taken a chance on him, to provided him with financial aid. He had a green card following the granting of political asylum, but wasn't a citizen. And he is our CDC director in Uganda. after having been CDC director in Ethiopia. He was able to go back there in that role. And is deservedly very proud of the work that CDC has done there, especially the recent work around the Ebola epidemic, where there was just one person who died in the most recent epidemic. And much of that has to do with a very fine Ugandan epidemiologist that CDC has trained in the Ministry of Health. So we know the transformative impact of education on the life of one person. We know the transformative impact of research on the life of millions of people, as your school indicates. So we're at a moment where this immense achievement we've had in global health, symbolized by these halls, symbolized by the work we've done in smallpox or polio or cholera or HIV or malaria, and the immense investments that we've made. Over the past 10 years, there's been a 10% year-on-year increase in the investment in global health. At the State Department, we now spend more on malaria than all of our efforts in Europe, for example. We've achieved a lot, we've invested a lot. Yet we know that when we step back, despite this great achievement, we also see areas of utter stagnation, where we haven't made the results that we have sought to make, despite much effort, much well-intentioned activity. We haven't made the results in areas even where we know what to do. I was reminded of this also by my trip to Uganda. I was there focusing on one of their State Department priority areas, which is saving mothers in that critical 24 hours of labor and delivery. We know how to save mothers, we know why mothers die, and we know what can be done to prevent their death. It's quite straightforward and so very, very difficult. I was reminded by hearing of the story about Cecilia Otim. In some ways it's a very typical story, and in some ways quite remarkable. She was a 34-year-old woman at the end of a normal pregnancy. She delivered her first child, a healthy baby girl, by cesarean section, but started to have difficulty breathing a few hours later, and there was no one available to help care for her. She was alone with her mother when she died from the complications of her surgery. So in many ways, she was unremarkable. About 60% of Ugandan women give birth with no one attending them who has training. She was, in some ways, she was quite remarkable, though. She was the youngest heart surgeon and the only female cardiologist in Uganda. So her death didn't only create her orphan infant, but it left thousands of people mourning the loss of all their loved ones who would have received care from her. And it was sort of one of those terrible ironies that someone who so much had been invested in, who was trained to do such difficult things, could die for such ordinary reasons. So we know that we, in so many ways, have so much left to achieve, and at this pivotal moment we need to look forward and determine where we go from here. Now, why is this a pivotal moment? First of all, it's a pivotal moment because of the domestic financial pressures that the United States face, and the same pressures that are faced by our colleagues around the world. When I travel and talk to my colleagues in country, they are quite surprised to learn about the changes that have happened in the U.S. since the recession. The fact that 50 million Americans now qualify for food stamps, the number of home foreclosures, the sense that we won't return to pre-recession employment levels till the end of this decade. These domestic financial pressures that we face, coupled with the same pressures being experienced by other donor nations, really with the exception of Norway, mean that the year-on-year increases that we've seen in global health are not going to be there. We face significant budget pressure in the United States in global health. Many congressional staffers and members of Congress have really warned us that we're at the high water mark in terms of congressional appropriations in this area. Global health has been very significantly protected from the cuts in the last two budgets. But it's hard to imagine that even with the strong bipartisan support in global health, even with the strong humanitarian objective that we face in global health, even with the impressive results that we achieve, that we will be fully cushioned from these pressures. This creates an immense responsibility on us to determine how we can reach our high, our lofty, our rightfully lofty goals in global health, and how we can prevent the spread of epidemic disease or the resurgence of the AIDS epidemic in this environment of financial pressure. We also know that despite our efforts, as I said, we have seen stagnation in some key areas. We have found it difficult to overcome the challenges around corruption, despite our best efforts. We have found it difficult to build capacity in systems rather than the creation of parallel systems. And we have found it difficult to overcome the attitudes and the constraints of dependency rather than empowerment. We know that we could save more lives if we could overcome these factors, but we haven't found the best ways yet to do it. And we're at a pivotal moment, given the budget pressures that we face, to find ways to create new resources to do the important things that we wish to do by overcoming these challenges of dependency, lack of capacity, and corruption in countries. We also have exciting new opportunities. We have middle-income countries that can play roles as donors at the same time as they face significant healthcare challenges. We have countries demanding more autonomy and accepting more accountability. Rwanda knocks on our door hard, for example, and asks for more opportunity to take leadership in their healthcare system, and asks us to provide fewer parallel systems, but provide them with more technical assistance. So we're at a pivotal moment, created by necessity due to domestic financial pressures, created by the long-standing challenges that we've faced in building capacity in countries and overcoming shortcomings, and by the new opportunities in countries around the world stepping into accountability and providing new opportunities for new and diverse donor nations. Now, what does this mean to a university like Johns Hopkins and to the country in which you reside as we lead in global health? First of all, we need to look at ways that we can come up with new kinds of compacts with our partner nations. The Secretary gave a major speech in this regard at the recent Aid Effectiveness Conference in Busan, where we talked about the importance of moving from concepts of development to concepts of investment, and the importance of moving to agreements with countries so that over the course of the next 10 years or 20 years, not 1 or 2 years, but over the course of the next 10 years or 20 years, that countries can move to independence in healthcare. Over this last 10 years, as we've substantially increased our healthcare spending in global health, we now need to work with countries to find ways to shift from the U.S. operating parallel healthcare systems to our providing ways to offer technical assistance and strategic assistance, to play key roles where that we can make a unique difference, but that healthcare systems in our partner countries are financed and operated by their governments, by their local institutions, by civil society, and by religious institutions in those countries. That's important for several reasons. First of all, we certainly never want to be in a situation where our domestic financial pressures are so intense. And as you know, watching over the summer with the negotiations around the debt limit and other factors, increasingly the Congress has sought to put in sort of automatic measures to lower U.S. spending, for which even very worthy programs with bipartisan support will not be immune. And we see the budget for the State Department and the budget for the Defense Department bumping up against each other, which puts our global health budget, which is overwhelmingly at the State Department, in a zone where there's tremendous pressure. We have an enormous obligation of global health leaders to work with countries, not only with governments in countries, but with the religious organizations that operate a significant amount of healthcare capacity in countries, to work with companies where available, and civil society, to do the kind of planning and strategizing and implementation so that we can, over a period of 10 or 20 years, shift to healthcare systems in countries that are more locally sustained, where we won't be out of global health. I don't think the United States will ever be out of global health. I think that global health will continue to be an enduring, significant investment on the part of the United States. But we need to transition how that investment works so it can be more effective, and so we don't have a domestic situation where we face a cliff in some kind of funding and we cause a great deal of suffering as a result. That kind of planning and strategizing takes the leadership of an institution like this that can understand all the simultaneous factors that go into creating a healthcare system, that can help us really understand through your research what works and what doesn't work in global health, and can have the courage to be transformational, can live where we are today while we're planning for the future. This is really important work. As a part of that, we're going to need to help countries extract more revenues from resources, and one of the most fascinating discussions I've had recently was when I was in Zambia with the Norwegian government and the U.S. government, having the Norwegian government sort of coach the Zambians on how to get more revenue, more tax revenue out of their extractive industries. The Norwegians have an oil economy, and they've been very good at gaining revenue out of their extractive industries. And it was a really sort of fascinating, dynamic discussion. And Angola, Namibia, Botswana, Uganda, Zambia all have significant new extractive industries coming online. And there's a risk that those countries won't be able to capture that kind of revenue. And there's a risk if they capture it that it won't go into health and other areas that are important. There's a big risk it won't go into health because many countries assume that we'll fund their healthcare systems. And so we are having very important discussions around these factors. Now, one of the things the State Department that has done that's different in this past year has significantly increased the role of our ambassadors in global health. There was a time in the very recent past that ambassadors focused more on political, military matters, and the health programs and development programs kind of went around. Secretary Clinton has asked our ambassadors to take a very clear leadership role on all the U.S. government activities in countries, and in Africa in particular, the vast majority of the resources the United States spends around healthcare. And that has proved to be very important because our ambassadors are in a position where they can work with our talented staff at USAID and CDC and PEPFAR to advocate for the government stepping in with more resources and to advocate for government policy changes that are vital to this. So when I was in Uganda this last week traveling with our ambassador there as we met with the Ugandan government, he made what has been continuing a very strong case about the importance of Uganda stepping up and putting financial resources into healthcare. In the post-PEPFAR era, the Ugandan government has diverted quite significant resources, as has been widely reported in the New York Times and elsewhere, from healthcare expenditures into the military. And this is a great concern to us, especially given the kind of pressures that we face, and we've been very clear with them that this represents a very significant problem, and a problem that we'll need to address with them. So first area is this migration to a new kind of compact or a new kind of relationship with our partner countries, where we're not coming in and providing aid and operating a parallel system, where we're looking to countries And by country, I define that broadly, and not just the government, but the other institutions providing health care and invested as leaders in the society to operate their health care system. A second piece is, I think, that it will increasingly be important to understand the relevance of the work that we do in global health to Americans. And there are two aspects of that that I think will stand out in this next period. The first is the important work that global health does to protect Americans from the spread of infectious disease. You know, we see what happens when we don't do that. When we weren't able to do that with the AIDS epidemic, what a immense amount of suffering in this country, around the world, occurred. And we know that there is no other way that this work is done outside of the United States leadership, particularly through CDC, in detection and surveillance and control of infectious disease. And the immensely important work that CDC has done globally with ministries of health to embed in ministries of health and be able to be their counselors and advisors at very difficult moments, to train local epidemiologists who stay in their own countries and do such important leadership work. This is going to be very, very important. And I'll tell you that that movie, Contagion, I don't know if any of you have seen that, has gotten a lot of attention, and we have had congressional briefings on the movie, and at the request of congressional staff, to talk about how we do this work. And understanding this, ensuring that we're investing in it, and the beautiful thing about this work, of course, is it not only protects Americans, but it attracts all people in the world. But it is a responsibility that we have taken on, quite rightly, because no one else is in a position to do it, is going to be very, very important to understand. I think the second piece is the message that PEPFAR has taught us, which is that a domestic constituency makes a real difference in global health. The remarkable domestic constituency that brought us the energy and resources and achievements around PEPFAR of the American gay community and the American religious community coming together and advocating for PEPFAR year in and year out, and giving PEPFAR some freedom to move fast and strong and boldly, which anytime you do that, you make some mistakes, but we all do. But to move with that with a sort of confidence and resources and change the face of the epidemic around the world, particularly in sub-Saharan Africa. We know that domestic constituencies for our work in global health is important. It's also a challenge. So much of the important work we do in global health, whether it's around malaria or tuberculosis, is outside of the experience of most Americans. It's outside of a sense of understanding. We are, in our important work that we're doing around maternal mortality, though, we see a great opportunity to build a bond between American women and their families, and women and their families around the world. Because as we've talked about what it would take to save mothers in labor and delivery, to build on the work that PEPFAR has done in creating such an important platform in Africa. I mean, when you see the blood services that are now available in Zambia, for example, when I was recently there, that weren't available before, and the way those services can be used to leverage our work to save mothers, since the biggest cause of maternal death is hemorrhage. It's immensely important that we can build on that platform, or the decades-long work that USAID has done in maternal and child health around family planning and in so many other areas. Our opportunity to build on the platform that we've had, but to do it in a way that strengthens local healthcare systems. It's been very interesting as we've talked about this and begun to talk about this around the country. There is a great resonance amongst American women. Most American women can imagine, if they've had a baby, having the reality of dying in childbirth. American women, it's very interesting when you talk to people about about 1,000 women die every day in childbirth around the world. most women will relate the story of their own labor and delivery and the moments that they felt great fear, or their sisters or friends or their mothers. And in some way, this universal experience of giving birth, at the same time that American women know the safety in which they gave birth, and the fact that if something did go wrong, it was still going to be okay, allows them to put themselves in some ways a little bit in the shoes of women around the world who deliver alone or deliver with someone whose only experience is having had a baby themselves and can't get to a facility over very difficult roads or don't have the money to hire. And then when they get to a facility and they realize they're going to need a cesarean section, can't get to the next facility in time. You know, it was very chilling this last week in western Uganda. We were near the Congo border, you know, hearing the stories of the practice, which is so very common, of when women don't have the money to get from the first level facility to the next facility where there was a surgeon available, how they're sent home to die because there is no way to end this obstructed labor. So I think that we, understanding what we learned from PEPFAR about how important it is for Americans to be deeply invested in the work that we do in global health, we need to find ways to broaden that. And we need to find ways to broaden that in ways that help us build healthcare capacity. And the power of our work in maternal mortality, we hope, will be not only our ability to ground it in a domestic awareness and domestic constituency around saving mothers, but also to be able to recognize that there's no shortcut to saving mothers. There's no vaccine campaign or drugs that can be rolled out, as difficult as those things are, that it really takes delivering capacity in a healthcare system, skilled birth attendants, and facilities where women can safely give birth and can have cesarean sections when needed. So, relevance to the American people by the important work that we do around protecting Americans from infectious disease, and by building the domestic support and empathy for the work that we do, is going to be extremely important in this next era in giving in global health. Lastly, we're going to need to be able to demonstrate results. We can face a fatigue in global health and in development as a whole. When I was in Uganda this past week and we were talking about the 48 years that USAID has spent doing really important work in Uganda, and yet how much more we have left to do to make a difference. Our ability to demonstrate results and to demonstrate progress and to demonstrate the potential for transformative change at scale, to be able to demonstrate that we're not only doing well-intentioned and worthwhile activities, but that we're finding those levers that can add to momentum and that can take countries to a new place, that we can make a difference in those kinds of results, is going to be extremely important in a world with many demands and a world with greater fiscal constraints. The kind of research you do is central to that, so we figure out what works and what doesn't work. We have also found in reviewing the research that focusing on women and girls and investing in the health of women and girls creates significant leverage for healthcare systems as a whole and for the advancement of societies. We have made significant investments to help women and girls choose the timing and spacing of their families through the very important work that USAID does in family planning. And we know so many times your researchers have been our partners in this work. This is extremely important. we have found that investing in women's and girls' empowerment in healthcare and education are some of those important levers that can help lead us to transformational change. So in this next era, in this pivotal point, what I'd like to ask you to think about is how you live in this world with doing these grants and these activities while you help us through this university create this next world. A world in which we can work with partner countries for their own self-sufficiency and self-reliance. A world in which we can make the case to the American people that our investment in global health is so relevant, both because it protects them from the enormous threat we face from infectious disease, and because that they can live in another's shoes and understand the difference that we can make in living out our values. And that we find those important moments, those important ways where we can make the most difference, where progress takes over from sheer activity, where we can make the most difference and we can demonstrate results that can move things forward in a transformational way. This is our challenge together. You can be very, very proud of your government and the American people. On Saturday morning, I was with our ambassador to Uganda, Jerry Lanier, and all our global health leaders in Uganda and the Minister of Health from Uganda. And we opened the new blood transfusion center and blood bank in Kampala. An important achievement of PEPFAR, managed by the CDC. And that national center is married to a network of 7 regional centers that are being prepared around Uganda that will provide safe blood supply, which will prevent the spread of HIV and AIDS, prevent the spread of hepatitis, offer the kind of blood products that mothers need to stop hemorrhage and survive labor and delivery. And that is some of the best expression of the deep and abiding values of the American people. Our commitment to saving lives because we can, and therefore we must. And now we need to do it in a way that builds to the kind of self-reliance that means that we'll be able to save more lives and build stronger nations and achieve our very, very, very high goals, even at a moment of domestic financial constraint. I know you will be leaders in this next era, as you have been for this past century in this area. And I'm grateful to have had the opportunity to be here with you. Peter, thank you again for the invitation. And I would be really pleased to hear your thoughts and answering of your questions. Thank you very much.
Use a mic that is on. It's a big web tap.
I can repeat the question, so who wants to go first? Yes.
I know you've probably had this question a number of times recently, but I understand that the plans under whatever the quadrennium development review process is that GHI should eventually, and I think the schedule is for next year, to be nested under USAID, and that USAID then would have wide-ranging authority to lead the global health initiative. So I guess I'm asking you, how's the time frame, how's the schedule going? Are you optimistic about that? And where do you predict you'll be working, actually, sometime middle of 2013?
Well, thank you. You know, I came out from Minnesota, which is, and as Peter tell you, he's been gone for a long time. We can still consider him a native son. to take on what has really been a very interesting leadership challenge, an opportunity of working across all the federal agencies working in global health. And one of the things that is a great strength of the United States is that we have a diverse set of agencies working in global health, each of whom bring a very important and very distinctly different perspective to this challenge. USAID brings this very important perspective of development, which looks at how everything is related to everything else. So they're so helpful in discussions by looking at how healthcare is related to democracy and governance and education and economic development, and how those things are all linked. CDC comes from an epidemiologic heritage, which is about following the data and moving quickly to avoid the loss of life and understand and contain. PEPFAR has its heritage as an emergency program and kind of a just get it done heritage. The Peace Corps is really fun. They're very cheerful, resilient. The Department of Defense does very important logistical work. NIH, asks and answers the big questions with your help. So what the Global Health Initiative has done is to take all these agencies together and to say, we're trying to do hard things in hard places. We've set high goals. How do all these different perspectives bring this together? And in that, Secretary Clinton set up a new practice for the State Department of having a 4-year review called the quadrennial, the QDDR, Quadrennial Development and Diplomacy Review. Is that what that QDDR stands for? And one of the elements of that, as you mentioned, is to think about whether the Global Health Initiative should transition from the State Department's leadership to USAID's leadership this year. We've had a very solid, effective intergovernmental process around that's been underway. The decision will be up to Secretary Clinton. While we've had the process underway, that decision hasn't been made. That will all come into focus later this year. But I think one of the things we've really learned from the process is this comparative advantage of the different agencies. And that when we can leverage that comparative advantage of the different agencies against these problems, we get to a better outcome. Because people look at these challenges in a different way, and none of the ways is the right way. They're all the right ways to look at it. So the specifics of how that process will end up and the timing of which will become into focus in this next period, but I'm not sure exactly when.
Hi, thanks so much for coming and talking with us about the Global Health Initiative. My name's Beth Frederick, and I work here on an initiative called Advanced Family Planning, which is an advocacy initiative that's designed to try and encourage national governments to put more financial and political support behind family planning. And in our work over the last several years, we've really come to work very closely with governments and with USAID. And many of the governments in Africa that we work with are quite sobered by their disproportionately young population and what's going to come, what's coming down the pike, combined with the donors having the financial realities that you talked about. To bring us to Uganda a little bit, where we work quite intensively, that's coming up against a government that thinks that a bigger population is going to solve some of their economic problems. And I wonder whether you felt in this recent visit any more of a shift. We're starting to see a shift by the president and some of the government officials that they recognize that family planning is critical. But I'm wondering if you heard those messages about population and whether the rhetoric's changing a little bit in Uganda.
Well, first, thank you very much for your service. This is a really important area for women and their families to be able to decide when they want to have their first baby and how close they want to have their children together is so important. It's tough it was tough in Uganda that in one hospital we were at, what's the usual first age of the mother when she has her first baby, and it was about 14. and way too young. Women have tremendous challenges in giving birth. Some mothers as young as 13. So, I didn't detect at this point a change in rhetoric there, but you have to think that that will come over time. It is, it's such a challenge in so many countries. I think that we have to provide, leadership in this area, both in providing family planning services around the world and in making the case that everybody benefits when women and their families can determine how soon and how close together they want to have their children. But this is going to be a challenge worthy of all of our work, I think, for the rest of our lives. It's a big one.
Thank you very much. My name's Ron Gray. I've worked for many years with the Rakai Health Program in Uganda, and Tad sends his regards, by the way. PEPFAR has been absolutely critical to our work. It has revolutionized not only treatment but prevention. But we are very concerned about the upcoming PEPFAR renewal, given the financial climate and also the political climate. Could you speculate on the prospects for PEPFAR?
Well, PEPFAR is vital, and PEPFAR is deserving of the strong bipartisan support that it has, and the strong support that exists amongst the public and amongst American churches and in so many other communities. And it is transformative, not only for HIV and AIDS, but for the entire infrastructure. There's been enormous turnover in the Congress since the last reauthorization. And so I think it will be really important that not only the Congress but the American people understand what an achievement it represents and how it protects Americans. And the opportunity that we have to build on the PEPFAR platform, we have so much better research now, thanks to this institution and so many others, to understand treatment as prevention. And Secretary Clinton gave a speech really saying, now we can start to look out to the first AIDS-free generation. That doesn't mean there won't be any AIDS, but it means that with our strides around prevention strategies are so much better than when PEPFAR started. Our really good results when I was in rural Uganda, we have really good results on prevention of mother-to-child transmission. So the case is there to be made, and I think that it's going to be very important to make it to the American people, because this will be coming up right at a time that we will still be suffering the effects of this recession. But the case is there to be made.
Again, thank you for being here. I like the way you characterize global health as being inclusive of domestic health and international health. And I wonder if we couldn't use that idea to think about how to liberate some resources to invest in our common well-being. America spends $1 trillion per year in excess of what the next most expensive country in the world spends on its domestic medical system. $1 trillion per year. So if we think of global health as not only about us taking PEPFAR and other sorts of technologies to disadvantaged communities, but also to working as a member of the globe and thinking about how to provide higher quality health care in America in a way that generates and liberates that $1 trillion to reinvest in other things. It could be a win-win situation. So my question to you is whether it's possible at this point to ask the global health question to mean more than us sending our technology out, but also to have some of the best skills and technologies for producing health in foreign countries to come to America to help us liberate that $1 trillion?
Yes, I mean, in so many ways we've made it so difficult for Americans to now afford health care here. And I think that we do need to look at ways to have cost-reducing innovation that allows American health care to be more financially in reach for more Americans. And so I think as we look at global health and we look at how do we improve the health of all people, it's absolutely important that we look at the kind of innovations that can help improve people's lives here and can help do it in a way that people can afford.
Hello? Oh, there we go. I'm getting there. My name is Keith West. Thank you for speaking to us today. Everywhere in the world one works, especially in the developing world, one can find the American university pursuing public health science. Technology transfer. Somebody didn't like that term. Technology transfer, doing research in the community, and that's how one builds local capacity. Over the past decade, there's been somewhat of it's been difficult for the American university in nutrition and health, science and research to maintain momentum, maintain its leadership in scientific exchange, in building that capacity beyond the research projects that they're funded to do. And it's an important American resource. It's a diplomatic resource. It promotes peace. We can do research under any regime. We can collaborate under any environmental situation, in any political climate. Could you reflect how do you see the Global Health Initiative in the years ahead strengthening the ability for the American university, and thinking public health right now, to engage institutional capacity in the developing world, to promote that exchange, to build our strengths as leaders, to maintain that strength as in leadership, and to promote a very vital and vigorous technical exchange in advancing that public health agenda?
Well, thank you. And you do see remarkable service from American universities everywhere you travel around the globe. Students, faculty, research. It's a tremendous contribution that we make that I think very much expresses the values of innovation and very core American values. I think that the work that PEPFAR has done around MEPI, the work that the Fogarty Center and NIH does in investing in these areas, and I know the work that many universities do on their own are very vital pieces to that. I think we should think about more ways to do that, to build on those effective efforts.
So there's a question over there. So you have the hot, you have the hot feeling working microphone. This is just an example of how we need better infrastructure.
Yeah, technology, microphones, the whole thing.
Thank you. My name is Ritika. I'm a Master's of Public Health student here, and I have two questions for you. The first is, you mentioned that in the last year, ambassadors have been more involved in terms of global health, and my question is related to, as the leader of the Global Health Initiative, what you've noticed in terms of politicization of aid from the U.S. government, in terms of which countries it goes to, where it's used when it goes to the country, so what you've seen in your experience. And the second question is, the Global Health Initiative, I think, is a great move in terms of coordinating the aid coming from the U.S. government, but what about coordination of donors beyond the U.S. government? Do you think that there should be something like a Global Health Initiative on a higher level, or should it be done at the country level? What do you think?
Well, thank you. We're seeking to find better ways to coordinate with donors. In some countries, it can be quite crowded as every donor is looking at doing different projects, and it can place an immense burden on partner countries and institutions. So we've made some strides there. I think there's much more that can be done. We provide global health assistance in the areas where it can make the most difference, where it can save the most lives, where it can help build stronger nations, where it can help protect Americans. There are some countries we can't work in because we don't think the money can be well used, and obviously we have a strong commitment to the American taxpayer, even though there's a significant need and we would like to do more. So we look at very closely where we make investments, and we look at it around the question of where we can really make the most difference in global health and where we can be sure that our dollars will be well spent. All right.
It's 5 o'clock, and I think it's time for us to thank Lois. And in the Finestone Hall on the second floor, we'll have a reception. Lois will be able to answer some more questions, and you get to meet her up close. And thank you all. See you upstairs. That was wonderful. That was, yes, terrific.